Special tests related to knee stability. As mentioned in the introduction to this program, the knee does not have an inherently stable bony architecture and relies upon the ligaments and capsule for stability. The tests for the integrity of the collateral ligaments and the anterior and posterior cruciate ligament will be discussed. Collateral ligaments. Medial. With the patient in the supine position, allow the thigh to remain on the examining table to assist patient relaxation. Abduct the leg and stabilize the lower leg between the examiner's arm and body to allow both hands to be free. Apply one hand to the lateral aspect of the knee and with the other hand palpate the medial joint line. A valgus stress is then applied to the knee, initially in full extension and then in approximately 30 degrees of flexion, while palpating the medial joint line to detect any opening or separation of the upper tibial margin from the distal femur. Medial opening of the knee in extension as well as flexion implies a more significant instability and consequently more structural damage than does opening in flexion alone. Lateral. To test for lateral instability, adopt the same position as for testing medial stability, but this time the fulcrum is placed on the medial aspect of the knee, and with the other hand palpate the lateral joint line. Apply a varus stress to the knee, both in full extension and also in 30 degrees of flexion. Again, instability demonstrated in full extension implies more structural damage on the lateral side than does instability which is only present at 30 degrees of flexion. Stress views can confirm the diagnosis, and if patient relaxation is not possible because of pain, the use of local, regional, or general anesthesia may be indicated. The examiner is reminded that for any ligament test, comparison must be made with the opposite knee. Anterior cruciate ligament. The primary restraint to anterior displacement of the tibia on the femur is the anterior cruciate ligament. Anterior drawer test. The anterior drawer test is performed with the patient supine and the knees flexed to 90 degrees and the feet flat on the examining table. Stabilize the foot by gently sitting on it and cup both hands around the back of the upper tibia while the thumbs palpate the anteromedial and anterolateral joint lines. Assure the hamstrings are not contracting by palpation posteriorly. Attempt to draw the tibia forward from under the femur, which would signify a positive test. Compare with the other knee. Lockman test. In acute injuries to the anterior cruciate ligament, the drawer test may be negative because the secondary restraints to forward displacement of the tibia remain intact. Also, pain, hamstring spasm, and a tense hemarthrosis may negate the anterior drawer test done with the knee flexed to 90 degrees. The Lockman test has been shown to be more accurate in the diagnosis of acute anterior cruciate injuries. In the Lockman test, the upper tibia and lower femur are grasped by the examiner's hands while the knee is held in approximately 10 degrees of flexion. Forward sliding of the tibia in response to a forward pull on the tibia indicates a positive Lockman test and is diagnostic of an anterior cruciate ligament injury. There is also a lack of a definite endpoint in contrast to the sharp definite endpoint in a negative test or when the anterior cruciate remains intact. Pivot shift test. With chronic tears of the anterior cruciate ligament, the secondary restraints become lax and an anterolateral instability becomes manifest. In full extension, the anterolateral aspect of the tibia subluxes forward from under the femoral condyle and reduces during flexion. To demonstrate this phenomenon clinically, the patient lies supine and the leg is elevated by grasping the tibia above the ankle. Internally rotate the tibia and apply an anterovalgus force over the upper lateral aspect of the lower leg. Passively flex the knee and at approximately 30 to 40 degrees, the tibia will appear to jump posteriorly into its reduced position. Likewise, progressing from a flexed position, the tibia will appear to jump anteriorly as full extension is approached. Posterior cruciate ligament. Posterior sag sign. With the patient lying supine and the knees flexed to 90 degrees, observe from the side. If the posterior cruciate is torn, the tibia on the affected side will sag posteriorly, and the tibial tubercle will be less prominent. This posterior sag may also be noted with the patient lying supine and both hips and knees flexed passively to 90 degrees. Posterior drawer test. This test is performed in a similar manner to the anterior drawer test, but in this case, posterior pressure is applied to the upper tibia, and in the presence of a posterior cruciate ligament tear, the tibia will be observed and felt to displace backwards. The drawer tests are normally performed at the same time, but it is essential to first look for a posterior sag. If the tibia is already displaced backwards, then performing the anterior drawer test will merely reduce the posterior subluxed tibia to its normal position, and this does not indicate a torn anterior cruciate ligament. This concludes the examination of the knee. The examiner is reminded that symptomatology reported about the knee, especially in children, may in fact be referred from pathology about the hip, and a thorough examination of the lumbar spine, hip, foot, and ankle must be carried out.